Now we're very honored to have Dr. Takami Sato, who has... Clearly, a lot of you know him. Anyway, Dr. Sato has also been a huge help in planning this meeting. So Dr. Sato is going to talk to us a little bit about adjuvant therapies, and we'll do Q&A after this. And I think Dr. Sato is also going to be here with us through the day, and so there'll be time for questions later, too. So thank you, Dr. Sato. And let me... And which one's this one? And then, or you can click.
Oh,
This is forward and back, yeah. Okay.
It's coming. I don't see that. Ah, it's gone. Excuse me. So good morning. Welcome to Philadelphia. And also thank you very much for Melanoma Research Foundation to have this opportunity. So I was given a very difficult topic, so I think we have maybe 1 hour of question and answer maybe. However, again, I have to admit that it is not final, and we are working every day to find a better job to do this. But my topics here today is advance in adjuvant therapy. So that is the most critical question that the majority of you have. So first of all, this is a kind of a routine for the scientific talk. I have no disclosed conflict of interest, but since there's no medicine approved by the FDA for uveal melanoma, so therefore I have to discuss the medicine that is not approved for melanoma, but for the other disease. Also, I want to show this to everybody. I met Greg 2007, almost 5 years ago. And without Greg and then Sarah, probably we don't have this meeting here. And physician learns many things from patients, and they keep calling me, emailing me, and then asking me questions, and then sometimes educate me. Also, whenever I got an email from her regarding the Melanoma Foundation, I should say yes, because that is our responsibility. So I want to thank you to Greg and Sarah to organize this type of activity. And then I think very important, we have to work together. You should keep asking doctor questions and let them educate a little bit. And then sometimes that give us a clue to find a new treatment. So therefore, don't hesitate, and then don't ask questions, please. So it's kind of, what's an adjuvant? That's a kind of question. Sometimes you call it neoadjuvant. So as Dr. Shields mentioned, whenever they discover something, sometimes probably we can give something up front and then just treat later. That might be a possibility. That has been done for the breast cancer. But adjuvant therapy is additional cancer treatment given after the primary treatment, which is either radioactive plaque, or enucleation or laser, to lower the risk that cancer will come back. So adjuvant therapy in general right now may include chemotherapy, radiation therapy, and hormonal therapy, and targeted therapy that Dr. Woodman talked this afternoon, or biological, in other words, immunotherapy. So we should find out the best one from this list to decrease the incidence of the systemic spread. However, major challenge in the treatment of uveal melanoma is, as Carol mentioned, or Jerry mentioned, they have done an excellent job. In the past, all eye is removed. Now, most of the patients can keep the eye. Treatment for the primary eye melanoma has improved dramatically. However, that does not result in the prolonged survival, because most of the patients probably has micrometastasis at the time of treatment or diagnosis. But I have to tell you, even so, probably immune system may be eradicating majority of cancer cell. So therefore, that is not, I don't want to scare you, okay? But the problem is probably at the time of diagnosis, some circulating tumor cell in your body. So some of them tumor are settled in the body like a liver, and then fighting against victim immune system, your immune system, and then cancer, and then eventually cancer. Sometimes cancer cell win to develop the mass. So the strategy for the improvement of survival is a threefold. First of all, risk assessment, because if you have a risk of, again, patient may say, okay, if it is 1%, according to me, it's 100%. However, as a physician or a general oncologist, we have to think whether giving some additional treatment is going to be beneficial or not. In other words, if the risk of system recurrence in general is 1%, we are very conservative in offering something, because 99% patient is nothing, is not going to happen anything. So therefore, risk assessment is very important. So, and then what's the threshold of the risk? That's a matter. What kind of treatment you have? For example, breast cancer patient tend to receive chemotherapy, radiation, because we know that the treatment is very efficacious. But on the other hand, giving a radiation to somewhere at the standard dose may not work for the melanoma. So therefore, we have to choose the patient population very carefully. So as of today, my risk threshold is 50%. So if a patient has one ratio to have the recurrence, I might think something to interfere. But in the future, if I have a miracle medicine, I might say, or with no toxicity, I might say, okay, you can take it. All right, so the second stage of the approach is adjuvant therapy. That is my major topic today. And then I probably don't have time to talk about the early detection, how to manage it, but this is a very controversial field, but if you have any question, probably we can talk about later. Now, risk assessment, probably I don't need to mention too much because Carol and Jerry nicely present the summary of that. As you say, as she said, size of tumor is very important prognostic factor. So if tumor is big, you have to be careful. As she said, anterior location is a very important risk factor. And then if tumor is embedding out from the eye, that's a very significant risk factor. So if you have a biopsy or remove the eye and then tumor show the epithelial itself, it's kind of very foreign language to you, but this is more aggressive type of cancer. And with mitosis, mitosis is how frequently tumor is dividing. So if we see that 20, 30, maybe I would say, okay, tumor is very active. On the other hand, 0, 1, tumor is not so active. Then this is not going to happen in general because local treatment is excellent right now, but some small number of patients has local recurrence, and that means usually tumor cells are spread during that recurrence. So that's kind of high risk. And more importantly, there's a two breakthrough over the 5 years that give you more information, but that also give you and give us a challenge. So now we know that who might have a risk, but the problem is also a doctor doesn't have anything to offer. So that's a major challenge. But again, this is the first step to know, who is going to have a problem, and then we have to focus on our treatment. Most of them are experimental to this population to change it, and then if we are successful, we can offer this to other people. So therefore, this is very important information to find out what kind of patient we have to spend the time to talk about experimental approach. So the monosomy 3 HQ amplification, so-called class 1, class 2, probably you might have heard this many times. So this is data from England, Dr. D'Amato, and then this is the lowest survivor is so-called the chromosome 3 monosomy missing, and then acquisition of the HQ chromosome, so-called the HQ amplification. this type of genetic findings indicate approximately 70% patient eventually has a problem. But on the other hand, if tumor doesn't have any abnormality in chromosome 3 and 8, their prognosis in general is, generally speaking, is very good. So you'll be confused with class 1, class 2 chromosome. I think I would say majority of the case it is overlapped. So as you see, class 1 is generally good, and then the minimum abnormality, so-called the disomy 3, disomy 8, and disomy 6. This is class 1A basically. And small fraction of the class A patient has some amplification of a gain of 6P. That is a little bit driver. And these are a little bit different kind of population patients who develop the metastasis a little bit late. So we have to be really careful, but usually that doesn't happen in the liver, but other places. But class 2 is mainly the monosomy 3. So there is a significant overlap, but there is some exception. Even large tumor, we see the disomy 3. Okay, and then what's the meaning of that? We don't know yet, but the class 2 is basically monosomy 3. And then in the Dr. Hubbard's group, think chromosome 8P is important, but we think 8Q is more important. But anyway, if a class 1, class 2 is found, that predicts potential recurrence. And sometimes the tumor is very small, and then we're surprised to see the 8Q amplification of monosomy 3. But again, whether a small tumor has same as large tumor, probably a little bit different, but nobody knows yet. And then I showed this before. If you want to do this self-assessment, and this is available. This is very good. May not be perfect, but to find out your potential risk. But you just use this as a tool to understand your biology of your tumor. And go into this internet and then just click it, and then you have to say, yes, and I follow your requirement. So example, a 70 years old gentleman, unfortunately, male has a relatively poor prognosis. And then this is not discrimination, but all the elderly people has a really poor prognosis. So therefore, we put the whole information in. And the anterior location, ocular melanoma, and large tumor, and extrascleral extension, monosomy 3, you can expect the risk like year 8, 18% patient can just survive. So it's kind of very high risk. On the other hand, if a patient is a female patient, younger, and then small tumor, no extra extension, and then disomy 3, so only 15% patients has death, not only from melanoma, but for other reasons. So it's very small risk. Now, that is really better than 10 years ago. So big challenge is what you can do for that. And as of today, this is standard care is just observe it. Because there is no miracle treatment. And but if you have a high risk, I'm going to talk about a couple experimental approach. You have to sit down with the doctor and then talk in very careful way. But as of today, since there is no curative treatment for the metastatic melanoma, maybe some exception, but in general, we have to observe this patient more carefully. Carefully mean more frequent testing, like MRI, ultrasound of the liver. And then once we find it, now it's a time to fight. So therefore, we have many approaches, and then other institutions like MD Anderson has new clinical trial, Sloan Kettering has trial. So it's much better than 5 or 10 years ago, because 5 or 10 years ago, uveal melanoma metastasis is a tumor that nobody want to touch, because prognosis is universally poor. But now we have several institutions who has better approach, better understanding, and better treatment. So therefore, it is worth finding out the problem earlier than late. So problem of adjuvant treatment is number one, no approved treatment for the melanoma, uveal melanoma itself. Then problem for the adjuvant is, okay, you have some high risk, but at the same time, if I say 70%, you might think, oh, I should be in the 30%. So therefore, doctor have to be careful. If treatment is very toxic, you are giving a treatment to the 30% patient who doesn't need it. Sometimes treatment may be lethal. We might lose some patient by the adjuvant treatment. So therefore, it's kind of very careful. Have to be careful in offering something to the patient who may not have any problem in the future. So that's a kind of an issue for the adjuvant treatment. So you also have to think of it. Should I take this toxic treatment or not? I may be in the 30%. This is just only the total kind of, just odds, not for me. Then other thing is most of the cancer treatment, long-term side effect is not known. Because treatment is given to the metastatic melanoma patient, and then some of them die. So therefore, there is no long-term track record. So therefore, should we use chemotherapy agent to the patient who might not have any melanoma metastasis? That's a kind of dilemma, and also patients have to think of very carefully. Especially for the younger generation, they may have kids. We have to talk about preservation ovary or sperm. Why we have to do that if their risk is 40% or 30%? That's kind of major challenge. Well, you have to be careful in thinking of it. Also, doctor have to be careful in talking about that. Now, generally speaking, cancer oncologist is find out or try to choose the medicine to prevent the metastasis. So that usually came from the evidence that medicine work in the patient who already had cancer. So that's a general concept. So if the medicine doesn't work for the patient who has already cancer, it may work, but it's a little bit difficult to justify the ineffective treatment to prevent potential metastasis. So that's the issue. And then majority of adjuvant trial came after the completion of the stage 4 disease. So therefore, if we find something good, probably we should use that for the other patient on the prophylaxis. Only one exception is a medicine so-called Avastin. Avastin is approved for the colon cancer. And there is a clinical trial to use Avastin as a prophylaxis for different type of cancer, because knowing that probably prevention of the new vessel may be important. So even though Avastin itself is tiny bit response rate, 5%, 10%, but there is a clinical trial ongoing to prevent the new vessel, to prevent the cancer spread. But the majority of case, general concept is you should use a medicine which is effective for the patient who can visible tumor. And then these are list of medicine that our investigator is working. And then we're going to talk about Sutent. I have to mention at front, Sutent is not miracle medicine, but the Sutent, we know how to use it. Sutent, we know have some efficacy in metastasis. So therefore, we are using Sutent, but eventually we might have to replace Sutent with something if we have better treatment. And the HDAC histone deacetylase inhibitor, Dr. Udman is going to talk more. There are many potential so-called targeted pinpoint attacker, including MEK. You probably know about this. This is a clinical trial ongoing. c-MET inhibitor, probably clinical trial is coming sometime this year or next year. We are doing anti-IGF-1 receptor antibody clinical trial for the so-called stage 4 patients. And protein kinase C inhibitor is in phase 1 right now for metastatic uveal melanoma. So if it is effective, we can use that, And the anti-BCL2 is this is kind of induction of the death. If we block it, tumor tend to die. So this medicine may be tried. Again, the GNAQ, GNA11 molecule is difficult to attack. But if we have some way to attack it, or potentially immune reaction against mutated protein, we might use that for the prevention. And then these two big, topics. Probably if you type in, there's two miracle medicine. One is anti-CTLA4 Yervoy ipilimumab. Other one is anti-BRAF inhibitor. BRAF inhibitor is not going to work for eye melanoma, but maybe anti-CTLA4 antibody might be useful. And then similar medicine, anti-PD-1 antibody, is now in clinical trial. I think uveal melanoma may have a similar benefit, like skin melanoma, but this is not approved yet, but it's clinical trial. This anti-CTLA4 antibody is approved by the FDA. The issue is whether we should use that for the prophylaxis or not. That's a big issue because the anti-CTLA4 antibody response rate is very low. And then 20-30% patient had autoimmune disease. Should we use that for the patient who has 30% risk of nothing, not benefit of nothing, and then should I create the autoimmune disease which may require steroid forever? That's kind of big kind of debate and question, but this might need to be checked whether that is useful. But again, first thing is that we have to make sure anti-CTLA4 antibody is effective as skin melanoma others. There are many things. So the warning flag come if time is up. Okay. I just speak a little bit slowly because there are so many medical jargon. So, but I may be running out of my time. But if time comes, I stop. So there have been adjuvant trial. But you might not know about that because they are not so positive. But there have been trial. So DTIC is approved for the skin melanoma. So therefore, why don't you use that for the prophylaxis? Even skin melanoma, DTIC is not proven to be efficacious in prevention, but there's an adjuvant DTIC trial a long time ago. Unfortunately, the result is same as non-treatment. So therefore, we conclude that DTIC is not effective to prevent metastasis. In fact, giving DTIC to the patient who has stage 4 disease metastasis, probably response rate is less than 10%. And then, since liver is most dominant organ of metastasis, why don't you give upfront chemotherapy to the liver to kill all tumor? So that has been done. And then, unfortunately, toxicity is significant. So therefore, most patients cannot tolerate, and then survival is very similar to the control. So therefore, this treatment also requires some surgical placement of the pump. So, and then I think in Europe right now, I think we have somebody from UK, and they can add some information. But I think there is an IV chemotherapy prevention trial using a photomastine. That's a chemotherapy medicine.